game-changing discussions on the big ideas that shape our thinking. This is One2one.
Richardson Ajayi is a renowned healthcare entrepreneur and investor, and founder of the Bridge Clinic, a leading fertility center in Nigeria. He's passionate about addressing the country's healthcare challenges and democratizing access to quality healthcare. Dr. Richardson Ajayi, welcome to One2one.
Thank you for inviting me.
Thank you for coming along. I've looked forward to this for quite some time. You are quite the pioneer of modern-day healthcare in Nigeria, aren't you? You birthed the Bridge Clinic along with your wife,
yes.
Pamela. So tell me about that. That was quite bold, wasn't it? You were venturing into quite a new terrain, both clinically and culturally as well. But was a career or specialty in IVF always in view for you, or did you just happen to fall into it at this point?
No, I think in my sort of first senior house jobs as a gynecologist, I was at Professor Winston at the Hammersmith Hospital. And for interesting reasons, I ended up in the IVF clinic. So as a young gynecologist, I was doing IVF at the Hammersmith. I was probably the only one in the whole of the UK who had that opportunity. But at the end of 6 months, I could do ultrasound scanning, I could do egg collection, I could do the transfers. So I was very integrated in, and then I was doing consultations. And what I realized were a lot of Nigerian patients come into the UK for what I was providing, the service I was providing. Geez, I was in my early 20s in those days.
And you were a popular man already, Hammersmith.
Yeah. And I thought to myself, this is something Nigeria needs. Okay, but I left Hammersmith and went on the normal circuits, did obstetrics and focused on my MRCOG, but with an idea that Nigeria needed quality fertility services.
Niggling in the back of your mind.
Totally. It took 11 years between that time and setting up Bridge Clinic. So I always saw that opportunity. And the interesting thing was that one of the first patients I saw when we set up Bridge Clinic were one of the patients I used to see at Hammersmith. So that sort of reinforced the idea that this was something that was necessary. So that's what led to the birth of the Bridge Clinic. I mean, there are many stories around that because nobody really understood what I wanted to do. It required a lot of capital, which I remember one of my early investors, Professor Serikel, blessed memory, and talking to him about, I wanted to set up an IVF clinic, he laughed. I said, what's that, number one? Number two, you're not a businessman, you're a doctor. And I said, well, yes, I'm a doctor, but I need some financial investments to be able to buy the equipment and set up my services. He said, setting up your services is different from running a business. And if you're taking up investments, you're running a business.
Sure.
And he helped me because he said, well, listen, I will invest, but you need to go to business school. So quite early on, I enrolled at the Chief Executive Program at Lagos Business School. And I think I was a CP 11. It was important because that opened my eyes to what he was trying to say, because you can't be in the consulting room seeing patients and run a business at the same time.
Absolutely.
So I started that journey. And that journey was running, in addition to being a doctor, going to medical conferences, I started going to business conferences and business schools. So I did the CEP at Lagos Business School. Then I realized I needed to deepen my experience. So I went to Harvard Business School. I did the OPM. That's a 3-year program. You go every year for three months every year. And I've also done scaling your business at London Business School. So I'm an alumni of Lagos, Harvard, and London Business Schools. In addition to my medical training, because I realized that medicine, healthcare requires significant investment.
Of course. Must be underpinned by sustainable business.
And to be able to attract investments, you need to understand business. You need to speak to the owners of finance in a language that they understand. And I think that's this help.
Absolutely.
Yeah.
I'd like to come back to IVF. Okay, and we've established, of course, that you are quite the pioneer in that area, in that field. And of course, at that time, I mean, someone asked you, what is IVF, and are you a businessman? I mean, it's a completely different terrain now. There are IVF clinics all over the place,
yes.
right now. But we still are, of course, practicing in an ethical minefield, are we not? But before we get there, can you trace for me the trajectory of IVF treatment as an assisted form of reproductive, an assisted reproductive technique in this country over time? How did we get where we are? Can you just run me through that trajectory from where you were in 1996?
Yeah, I mean, it starts before 1996 because I think the first reported births were from Luth, Professor Gio Osage, Professor Ashiru, and that was in the 80s. But it was an experiment. They had a birth, but I'm not sure they sustained the effort, or nor did they commercialized it in a way that was accessible to all. And then there was a gentleman called Dr. Wada, who also came back from the UK a bit maybe before me. He was also working in one of the hospitals in Abuja, and it was doing something. But I think what I did, which was a bit crazy at that time, was to step out and boldly say we're doing IVF as our sole practice. Everybody else was doing a bit of IVF where they were delivering babies. You diversify that risk. Yeah. But I think we stepped out and said we're going to be a full-cost fertility clinic.
So the Bridge was the first
full-cost fertility clinic in Nigeria,
dedicated wholly to IVF
in Nigeria, if not West Africa. But just dedicated to IVF and not doing anything else. So we were the first, and setting it up. But like I said, it was something that I was already doing, so I didn't think there was any risk.
Yeah, absolutely.
And especially as I was going to do it with the guys from King's, I started business school, and one of the things, the mantras was to learn to work on your business, not in your business. So even though I'd done IVF, I could do egg collection and transfer, I decided to turn it into a system that I managed. So I approached John Parsons, who was a good friend, and his team at King's, and I said, listen, why don't we collaborate? So we'll run our cycles in batches, get a batch of patients, get them ready, and then you guys come in, you do the egg collection and transfer. So it's a high standard, embryologists that are doing it know what they're doing, and I just control the system, do the consultations, of course, and make it work. So that was the idea. I got the first batch ready in November 98. Makeshift laboratory, 17 patients paid to have treatment. But John said, let's come over before you start stimulating them. Let's just see what the system was all about. And he came over and saw all the patients and said, Richard, one of the dangers of a new clinic is that the first patients, the early adopters, are very desperate. They usually will not get pregnant. So you can't treat this patient. I said, but they've paid me, and the money has been used to bring you here. So we have to treat them.
Spent.
Yes, totally spent.
Yeah.
He said, no, we have to treat you. He said, Richard, I'm not coming to Nigeria to lose my reputation. So that's your problem. I've done my job. We're not treating these patients. And I remember sitting down and saying, oh my God, it's a new business, I'm in trouble. But I think that sort of reminded me about the importance of ethics, because there's no point in taking money from a patient who has no chance of getting pregnant. The other thing John said was that we needed to set up an ethics committee as far back as 2000. So we got lawyers, we got clergy, and we tried to get a representation of the different groups in society to really look at Nigeria and say, what should we be doing? So we debated issues like surrogacy, embryo adoption, ovum donation. And so what should we be doing in Nigeria? And get advice from both Christian religious perspective, the Muslim perspective, lay women, and then the committee were very important in guiding us in the early years.
Absolutely.
Today we've codified all their advice, and so we have an ethics framework, and basically, they form, the couple, beneficence, make sure you're doing good,
Non-maleficence.
non-maleficence, you're not doing any harm, justice,
Autonomy.
fair, autonomy, respecting. So, and autonomy is very important in IVF.
Absolutely.
Because a lot of people are emotionally vested. They want to have a baby. Yeah. And they believe that once they've paid you, and this is where getting consent becomes important. Because the truth about IVF is that 1 in 4 people get pregnant that you treat. 3 out of 4 will not. Not because there's any problem with IVF, but that's just the nature of human reproduction. Yes. Because in your bedroom, it's 25 to 30% chance every month. Same with IVF, but IVF costs money. So the expectation is very high. Cool. So it's very important that as a clinic, you take time to counsel your patients so they understand this and don't rush into it. Absolutely. And get emotionally disappointed if it doesn't work. But IVF works very well in the right hands with a very good ethical framework. Absolutely. That debates today, how many embryos should we be transferring? I personally think never more than 2. Never. Increasingly, single embryo transfer. I know some people are doing 3, 4 in Nigeria because they know. But the honest truth is that if your laboratory is good enough, you don't need to do more than 2 because all you do is increase the complications to that pregnancy, and it's totally, I think, irresponsible.
Yeah, absolutely. And you've already, and I'm really pleased about this, started to touch on the the ethical dilemmas that exist. And we've talked about autonomy. Of course, your own autonomy is also important. Doctor's autonomy versus the patient's autonomy. You've just spoken about the fact that you will not transfer more than X number of eggs, and you reserve the right to be responsible in that way. But I would like you to delve a little bit further into this and talk to me about some of the common ethical dilemmas you confront in IVF treatment. Well, locally in this country.
Well, you know what I always say. I mean, when I'm talking to the staff at Bridge Clinic, I say it's not that difficult to achieve a pregnancy. If you're struggling, you can go to a baby. If you want a baby, you can go to a baby factory. You can adopt. You can see your neighbor. There are different things people do. Now, from an ethical framework, the objective is to go through a certain process that ends you up with a single pregnancy, because that's the objective of IVF. Now in Nigeria, people do different things. So a lot of patients come in. People have come to me and say, well, can you treat me with donor sperm and not tell my wife? The answer is no.
Absolutely.
Because that's an assault on your wife, and we will not be party to that. Right. Or the woman...
totally unethical.
Yeah, totally, it's not acceptable. So we have occasions when the woman doesn't respond and she needs donor oocytes, and of course she doesn't want her husband to know. We can't do that. We have to tell him, because we're going to get semen, a sperm from him. You can't use his sperm to fertilize donor eggs without his permission. So we are very open at the Bridge Clinic. We're very honest. I said to the patients, to the staff, forget the fact that they're paying you. Focus on what you need to do. Absolutely. And they may go somewhere else and get the treatment, but we will not compromise, our own values. And our number one value is ethical approach. We will not compromise that just because patient is paying you more money. No. So we're very upfront on that. So we leave a lot of money on the table.
No, absolutely. And I'm going to press a little bit further into that point. Surrogacy and gestational mothers. Talk to me about commoditizing childbirth.
Well, surrogacy is a minefield. And I think when we started, we had the first surrogate birth in Nigeria. It was a topic and an editorial in The Guardian, I think as far back as 2004. How did we do it? I mean, there's an NGO in the UK called COTS, Childlessness Overcome Through Surrogacy Courts. They are very strict guidelines, and we decided to adopt those guidelines as far back as 2004 when we did it. So because there was no framework in Nigeria, so we adopted those guidelines. And one of the things we don't do at the bridge is procure surrogates. We treat you, but you have to bring your surrogates.
Absolutely.
Because I think it's very difficult to get into that space, because sometimes surrogates, they're going to go through a pregnancy and they must make a decision to give the baby back. The legal framework to enforce that does not exist.
It doesn't. It defaults to contract law.
Absolutely. And which you can't really use contract law, because the owner of a baby is the mother who gave birth to the baby. So it's complicated. So we manage that by not getting involved. So we provide IVF services through you and a surrogate that you have brought. So you have made your arrangements with your surrogate, and we're very happy to provide you a service. We help by giving you the guidelines. We have very strict counseling. So we will not do surrogacy without both the surrogate having an independent counseling, the commissioning couple having an independent counseling, and there are questionnaires that they have to fill. And then the three of you sitting together. So there's no anonymity here. There has to be a full engagement. Because listen, it's your baby. Where is your surrogate going to live while she's pregnant? What is she going to eat? Is she going to stay at home with her husband? No, we have to discuss all these things. So we have very strict counseling, and very experienced counselors, Mrs. Abang and Mrs. Akinshilu. They do a fantastic job, and both they've been with us for many years. And so with that, we have never had problems, because some people after counseling say, no, thank you. Absolutely. I'm not interested in this, but I think it's critical, because you can't commoditize the process and just think because you paid the surrogate and you paid, no. I think that's taking it a bit too lightly.
Absolutely.
So I think and I think that's one of the problems IVF is having in Nigeria today, because the conversation is not deep enough and everybody's having a go, but it's a very, very complex subject. And the issues really have to be put on the table before you start. And sometimes you have ovum donors who come in, they think, okay, I'm going to get some money, but you got to put it on the table that you're young, you run a risk of the ovarian hyperstimulation syndrome, which can kill you. It's not common because it can be managed, but this is the kind of counseling that people need to have. And if you're not doing that, then you're not being ethical.
Absolutely. and we really do need to become a better educated society, don't we? And a more ethically responsible society.
Absolutely.
The key is society is not robust enough to process all of these issues properly, but particularly within the socioeconomic climate that exists at this point in time.
Yeah, I agree with you, but I think it's the responsibility of us as professionals.
Absolutely.
You got to dig in. I have had couples in the past, when I was clinically active, I couldn't communicate with because of language barriers. And if I feel I have not counseled you adequately, I will not treat you.
Correct. That's you exercising your own autonomy.
Absolutely, because you'll just laying yourself open to issues. Correct. At the end of the day. They must understand the risks of the procedure. They must understand the failure rate of the procedure, and they must understand their own involvement in the procedure. And if they are able to do that, fine, go ahead, because everybody has had the conversation and we all understand each other. But when there's that asymmetry in terms of understanding, then there potentially could be problems.
I'd like to press a little bit further into IVF, simply because it's one area actually that it gives us an opening into many of the issues, many of the things that are fundamental issues in Nigeria's healthcare system today. I'd like to talk about trends. And this, by extrapolation, is a statement about resources, asymmetry of knowledge, information, the socioeconomic environment that governs our existence. Talk about notable trends and what you're currently seeing in terms of the profile of your typical IVF patients in terms of age, occupation, social class, and lifestyle. I'm really talking about access. What are you finding in terms of demographic trends?
Well, I think at the very basic level, infertility does not recognize a socioeconomic status. It's a condition that affects everybody. As a result of that, we get everybody pitch up at the clinic, but of course, IVF is not inexpensive. So the ability to pay for the service now starts to stratify the society.
Which is precisely the point. I think.
You know, it starts to stratify the society. So you tend to get most of the patients who come in come from a certain socioeconomic group that can afford it. But you know, we're also a very connected society. You know, with lack of social infrastructure in terms of fallback, in terms of the government for social handouts or even health insurance, people have families and friends. So, you know, I have friends whose cooks have been treated, whose drivers have been treated because people will support them. And so one of the things we did at the Bridge Clinic quite early on was to try and see what we can do to bring the service to financially disadvantaged people. So we set up the Institute of Fertility Medicine with Lagos State University Teaching Hospital. The program is very successful. So basically, we provided all the infrastructure services at a discount. So people who went to LASUTH were means tested, and if you found that you really could not afford the services, then we gave you treatment at almost next to a fraction of what it would cost. I'm pleased to say we ran the program for 10 good years. Thousands of babies were born from that LASUTH program, but I think LASUTH terminated the program in November because they believe they now have the capabilities to continue to do this themselves, which is fine. But I think that challenge of access is something that we still need to sort out because healthcare cannot be for those who can afford it. It should be for everybody. And so what systems do we have to put in place? So at the Bridge Clinic, we have a CSR program where we treat a certain percentage of patients at significant discounts every year, just to make sure that there's access. Now that the IFM program is no longer there, we have to think more robustly in terms of how to bring more people on board who can't afford services. Because it can't just be for the rich. I think that's boring.
Absolutely.
It's not interesting at all.
Absolutely. So talking about reversing the trend of medical tourism, we've laid the foundation very nicely for that conversation so far in this discussion. I particularly like the fact that you spoke about Ajayi Memorial, and as you described that sort of reminds me of an early version of the Duchess Hospital, actually, or Evercare.
Yes.
And it's just amazing, phenomenal, just to conceive of the fact that existed then.
The 70s.
In the 70s. So obviously quite a lot has happened since, and there's been a failure of trust in the system. And we find, of course, that patients have been moving abroad to have medical treatment. And what it also means, actually, is that the country has been hemorrhaging quite a lot of cash, foreign exchange. But there are many who would say that there is now a trend that speaks of a reversal, simply because things are happening, particularly in the private sector. And you described very eloquently what's going on in the private sector, partly, and what needs to happen in the public sector as well to help move that along very quickly. But can you comment on the trend that you're observing now in the reversal of medical tourism back to this country, if it exists, to any appreciable degree, in your view?
No, I mean, geez, almost 30 years that I have come back to Nigeria, there's a total transformation of the space. I think we were early returners, if you like.
You were trailblazers.
Yeah, we were pioneers. We were young and foolish, I'd say. But we came back a lot earlier. But since then, I mean, you are here. A lot of people have come back.
Sure.
And a lot of people are bringing back the capabilities that we never had. And not only are they coming back, they're also bringing investments in. So the healthcare landscape in Nigeria has been totally transformed. It's a silent revolution that has taken place in healthcare. But of course, there are certain institutions we still need to build. The first is just that regulatory oversight to ensure that trust is embedded in the system and not in individual doctors. So that's important because at the moment, trust and quality is in the hands of the provider. And if the provider is not ethical and is not bothered, then he does what he likes. And you hear patients complaining. So how do we build a system that consistently delivers the value proposition? You need to have quality management systems, you need processes and procedures, and there's a governance framework. So there's a whole lot of work we need to do. That's the first thing. The second is, how do we scale these individual efforts into consistent, sustainable financial investments to be able to drive a pipeline of investments? So that's the second conversation, because at the moment, a lot of these services are only for those who can afford them.
Sure.
So how do we get the healthcare reimbursement system in place to ensure that we can really build scale in this? So I think there's still some work to be done, but certainly we've started the progress. There's been total transformation, and there's a lot that's going on today that wasn't available in Nigeria many years ago. Yeah, so it's
absolutely. Having said all this, dare we talk about adoption?
Of course. You lead the charge.
What would you say about the uptake and societal attitudes to adoption at this point? Because of course we can talk about IVF till the cows come home. We can carry on with that conversation, but of course that is also a consideration for those who aren't able at some point who don't succeed at IVF. Adoption is something that is certainly, it must be on the table. What would you say about societal views these days?
Well, I think there's a primal instinct in all humans to have their own progeny. It's natural. I want to have my own genetic offspring.
Of course.
And so that's the natural approach. So most people want to achieve a pregnancy by themselves. And if they do, that's the best way to do it. If it's not working, then you have alternatives like IVF. Even before you get to adoption, there are other hurdles to cross, like donor sperm, donor eggs, surrogacy. These are all conversations that people may need to deal with. I mean, the truth is nobody wants to have a transplanted kidney. But if the alternative is death, then a transplanted kidney is a very good idea. So it's that kind of conversation with donor gametes. And I think it's the same level of engagement when it comes to adoption. Yes. Because at the end of the day, if all your options are exhausted, to have either your own natural offspring or with the support of donor gametes, and that's not going to work, then adoption is a fantastic idea. And I think it's a question of understanding and counseling. But it's not the first choice, because most people just have an aversion to non-genetic progeny. But once that understanding is there, then I think it's a good option.
I mean, it's important not to talk about it as an inferior option either.
Absolutely not.
It's really important.
Yeah, it's not. I think when you need it, it's your best option. There's nothing inferior about it. It's the most superior option.
Absolutely.
And I think the point is understanding that. And once you understand that, and the counseling is done, people embrace it.
But what is your understanding of the uptake these days?
Well, I'm not involved in the process to give you statistics, and because I don't have that data. But I do know that it's something we have a relationship with people in our clinics who support patients in adoption, because it's not everybody that we can help.
Of course.
I mean, there's sometimes some people try IVF so many times that we're even embarrassed to treat them anymore, because you can't keep taking money from people where the results are not there. So after a while, then you need to counsel them about their options.
Of course.
And for some people, that option is adoption.
It's adoption.
And in which case we have agencies we have relationships with that we refer patients to, but I don't know what happens in terms of uptake in the end.
Sure. Absolutely. It has been an immense pleasure talking to you, Richardson Ajayi. Thank you.
Thank you very much.
For One2one.
Thank you.